I'm presenting a piece of research that is published in the Australian Occupational Therapy Journal, and this describes the implementation of CIMT across 3 publicly funded health services in Australia. My co-authors, all occupational therapists, are based in 3 different states and territories of Australia. And I'm presenting this because we know that there are a significant number of barriers to delivering CIMT. Therapists consider that often they don't have enough time, there's not enough staff, and they just don't do it. And we know from our Australian National Stroke Guidelines that less than 10% of stroke survivors, either as an inpatient or an outpatient, are receiving CIMT. When we look at the medical records of several thousand stroke survivors and look at those who specifically should be provided with CIMT or at least offered CIMT, that is people with some finger and wrist extension. So our aim was to translate the research that has been published by many of you in the audience today to find out how we could feasibly run these programs without additional staff, without additional money, and they were free programs. So it's a public health service in Australia, which means people didn't have to pay for it. Now, when I talk about Australia, some of you will know the geography of our large continent, but here we're talking about a program being run in the north of Queensland and in the central west of Queensland. So it's a very rural area. We have 6 programs and 16 participants across the continent. The second state is Sydney, where I was based at the time when these programs were run, and of course it's a large metropolitan city. The third state is Tasmania down the south, so it's a smaller population, a rural population, and often the outpatient therapists are part-time. They're often moved around to the inpatient area when there are staff vacancies, and that was a challenge. How would we run the program there, and how would they keep it running if staff moved? Our aim was to find out and then to target the barriers that we identified in the different sites to delivery of CIMT. And we know that from previous work that I've done and many others, that the barriers are different. Even within one hospital or one health service, the reasons that people aren't delivering an intervention, whether it's constraint therapy or mirror therapy, any evidence-based intervention, can be different even from one ward to another because of the individuals and the context. We also wanted to make sure that if we were going to put the amount of effort into running these programs, that the stroke survivors were getting good outcomes. So of course we wanted to be measuring the outcomes, and that meant also measuring the number of repetitions that were done so that we could see if the repetitions correlated with improved outcomes. I mentioned that this study had been published, and this is where you'll find it in the Australian Occupational Therapy Journal. And we have most of the tables and the data I'm talking about today of the number of repetitions, the hours that we spent and that each therapist spent on average preparing for their first program, and so on. The barriers that exist for delivery of CIMT have been studied in an earlier paper by a Canadian research group. So they sent out a survey to occupational therapists and physiotherapists who worked in neurology, and they got over 300 surveys back. They found that there was 2 groups. There was one group that had used constraint therapy before and another group that had not used CIMT. And for those who had not used CIMT, lack of knowledge about the treatment, and also about how to identify eligible people was a common barrier. They weren't confident about what to do. They also weren't sure about the amount of time and the number of staff, and that was a reason why they were not delivering CIMT, and that concerned them. And as you can see down the bottom, the non-users by far outnumbered the users. Those who had delivered CIMT said that really it was the patient-related factors that most concerned them and made it difficult to deliver CIMT. So whether people could do the exercises, whether there was enough range of exercises for them, and also the cognitive challenges, remembering the homework and the tasks they had to do for their homework, and completing some of the measures such as the MAL. Compliance with a fairly intensive program was another concern. Like the others who had not delivered CIMT, they also were very cognizant of the time involved and the number of staff that it took to deliver a program intensively over 2 to 3 weeks. So we went on knowing some of these issues would affect the staff in the different places in Australia across the 3 health services. And our intention was to see if we could get more stroke survivors to receive CIMT. Now, we didn't do any audits of the medical records at the beginning, which Lauren Christie will talk about in the next presentation, because we knew nobody had received CIMT in the past in any of the health services. So our aim was to count how many people received CIMT. And we had an intervention, not only that the stroke survivors received, but also that the therapists and the services received, to help improve their skills and knowledge and manage the personnel problems. So this is a common method used in knowledge translation or implementation studies. You don't just go in there and start doing the intervention, which might fail. You spend some time thinking about what can be the challenges, and you talk to therapists about that. We didn't do it in a formal, structured way. We had meetings where we discussed this and we reflected on them before the next program was run at the next site. Whereas Lauren Christie, because it was her PhD, did it in a much more structured way and learnt from and built on this pilot study. We measured the number of stroke survivors at each site who were offered CIMT each year, received it, and we also counted repetitions per hour, because we thought that would be a good measure of intensity, and fidelity is the word that's used in the knowledge translation research. We used tally counters that you can see here. So every stroke participant and therapist who was working with them had a tally counter, and people took them home. We're talking here only about outpatients, people who were at home at the time of receiving the program. We decided to take only outpatients because inpatients were more challenging. They had more competition for appointments. And yeah, for various reasons, we only offered this to outpatients. And of course, we were interested in the outcomes for the stroke survivors. When we were thinking about barriers, as I've said, we knew that they would be different for the different sites. And the very first program I was involved in as a mentor for a clinician, she wanted to deliver it for a group of 4 to 5 stroke survivors in North Queensland. And so we started thinking about what she needed to learn. She made contact with people like Dave Morris and with Ted Stevenson in Canada. We read the trials, the main trials, and looked at what measures had been used. We read the systematic reviews, and we attended a one-day workshop run by a colleague, Philip Fay, here in Sydney. We began sharing some of the materials too, so the next program could build on the behavioural contract that had been used and build on the workbooks that had been developed. And a core part of many implementation studies is developing a community of practice where one person learns from another, and you have this network of people who are all interested in improving their practice in an area. And Louise Massie, who was the first person to deliver the program in Queensland, then mentored the other therapists and helped them with problem solving. We've shared a lot of the resources on the StrokeEd website, which is a company that I'm involved in that runs education for therapists. And so you can access that free of charge if you're interested. So it has the behavioural contracts, it has the workbook details, and you can put your own logo or details on the top of the document. Skills, so it's all very well to know what to do, but how do you actually do it? So how do you learn to do the MEL? How do you do the shaping? These were a lot of the concerns therapists had. So people like Louise would model that to the staff in her team, and they would be able to see her doing some shaping with an individual and then practice it themselves. Each therapist took photographs and videos, and they used that in the training with their staff, which was really helpful. And of course, I've mentioned the mentoring and coaching, so individual staff could give feedback to the other students and staff who were helping. They became the local champions. That's the term that's used in the implementation world. They mentored and they were part of a community of practice. Many of you will already know that if you work in the public health system rather than a private practice, you need management support, because if you're spending 4 hours a day with one person, that's not typically what would happen in a public health service. So people needed to have support from management. They needed to plan and roster on staff. If you're a part-time therapist that only works 2 days a week, you need to then have other people that you job share with who would take on this work. So it was quite a complex roster of students, allied health assistants, and in some cases we had some unpaid volunteers who were keen to learn about CIMT that came in to assist. And of course, it was training for the helpers. Again, some of you will know this, but some of you might not. If you work with outpatients, people who are coming in for the community, it's quite hard getting the same room every day for 2 weeks, because there are dietetics groups, there are physiotherapy groups being run every day. And so you can't have the same space every session every day. So that meant moving around in some of the buildings and moving boxes of equipment for each of the different sessions. Mostly they had to buy equipment, and only one of the teams had used the Canadian Occupational Performance Measure, so they had to buy that and learn how to use it. And of course, various items of equipment for training. When we went on to collect outcome measures, this involved the COPM, as I've mentioned, and the MEL, which I'm sure all of you will have heard of. It's a self-report measure that's very easy to get hold of. We took measures at the end, before and after the 2 weeks. So people came in beforehand and had the measures taken, which would often take a couple of hours. Then at the end, within 1 week of them finishing the program, and then they came back a month later. We also have measures 12 months later for about half of the sample. We use in Australia the motor assessment scale, and so that was one of our standardized measures. We also use the box and block, which I think is my favorite outcome measure. It takes 1 minute to do, and it requires some hand function and some ability to transport your arm. We didn't use the ARIT, although Lauren Christie has used that in all of her sites, and we didn't use the Wolf motor function test. They weren't common tests used in the sites, and it needed to be, the outcome measures needed to be easy for them to do and quick for them to administer. Most occupational therapists will, I think, have a copy or have 9-hole peg test in their cupboard, and we use that. But of course, quite often stroke survivors couldn't pick up any of the pegs before they started the program. So you need to have other instruments as well that are objective. And as a researcher myself, the COPM and the MEL were self-report measures. The MEL was done every day as part of the preparation for the program to find out what people were doing. So they're self-report measures, and I wanted to make sure that we had at least 2 or 3 objective outcome measures, and that's what you will also see in most of the trials. A little bit about the CIMT program itself. We, of course, included intensive training and shaping, feedback and coaching. We had tally counters that we used. People used mostly an oven glove with Velcro tied around it to make sure that people didn't take it off in the middle of their session. And the transfer package, which we know is very important, with homework and a diary and so forth. I've mentioned that this was a community or an outpatient program for people who were anything between 3 to 6 months post-stroke up to 4 years. Everybody had some movement in their hand. One person didn't have any active finger movement, but did have finger and wrist extension. The programs generally ran Monday to Friday, 9 till 1, but we realized in some of the places that starting at 10 in the morning was better because the traffic in large cities is quite heavy and it's difficult for people to get in for a 9 o'clock start. And also people who are working as part-time therapists with children to drop off at 9 o'clock, getting started and set up ready to start at 9 was quite a challenge. And for stroke survivors who take a lot of time getting ready in the morning, it was also helpful to run till 10 o'clock, start at 10 o'clock. We also found that starting the program on a Wednesday or a Thursday was helpful, allowing 2 or 3 days of the program and then 2 days of rest. And then 5 consecutive days was a good way to run the program, both for the therapist as well as the stroke survivors. So in that instance, the program would run across 3 weeks, but still over 10 days. Everybody had supervision for the 4 hours that they were on site. And that would often have a shared roster. So I might see somebody on the Monday, Tuesday, and somebody else saw them on the other days. Mostly it was group sessions, but there were 2 individuals who were seen individually, and there was nobody else having their CIMT program at the same time. I'll give you an example of an individual. This was the man who was the longest time post-stroke, 44 months, so 4 years after his stroke. He was living in a rural area in Mount Isa in North Queensland. He was a taxi driver. He also played poker. He was a keen card player, and he taught basketball. He was a basketball coach. So his 5 priority goals were to be able to dribble a basketball, to tap on his steering wheel in his taxi along to music, so he wasn't fast enough to be able to do that, to shoot goals, and to play a season of basketball. Here's an example of the shaping. On day 1, he practiced seeing if he could bounce the ball once in a period of 30 seconds. Then on day 2, could he bounce it in a square? And he had problems with his wrist extension and being able to flex and extend his wrist quickly. And then by day 8, could he bounce the ball successfully for a number of repetitions and look up, preparing to send the basketball to his partner. To prepare for his shoulder pass, I mentioned that he had difficulty maintaining wrist extension, so we counted the number of seconds that he could hold the ball in place, and then he had to hold it and throw the ball successfully. For this man, you can see at the end of 2 weeks, he was faster with his 9-hole peg test. There were some changes in the COPM and the MEL, but I'd like to highlight his box and block test. So he was able to manage 6 more blocks by the end of the 2-week program. Here's another example of a man who wanted to use his electric drill. So we started off with a laundry bottle, and he had to squeeze the trigger with water in it, and he squeezed that onto a piece of paper or a towel. So you could see when he was getting the water to come out, and the therapist held it. The therapist was acting as his other hand. He also had problems with shoulder control as well as finger flexion, so he would practice touching a target on the wall in front repeatedly. By day 6, he was using a toy plastic drill, which was quite light, but had a trigger, and he had to combine the finger flexion with the shoulder flexion and hold the drill up for a specified time and do that repetitively. And then by the end, close to the 2nd week, he was able to hold his own drill but it's a two-handed task because it's a very heavy implement. But he was able to successfully do that. We recorded repetitions during the sessions, and they recorded the individual homework tasks. And so here we were able to record the average as well as the total number of repetitions. For Steve, so finger tapping on his steering wheel, and also turning pages of newspaper and holding the remote control for the television. You might remember we were interested to know how many participants and how many repetitions were done. So let's have a look at that. The first program run in Townsville had 5 participants, and then we ran 2 programs in Sydney over with a 12-month gap in between. Then Louise Massie ran another 2 single programs, and that man Steve was one of those participants. And then the second last program was run down in Tasmania with 5 people. Now, these programs were run a few years ago, and I'm disappointed to say that when these therapists change jobs, the only person who's still in the job, the original job, is down in Launceston. The CIMT programs did not continue. And what Lauren has done in the program that she'll describe shortly was to make sure that she trained up both OTs and PTs and assistants in the training sessions, so that there were always reserve people in those sites to run the program. And that was our mistake, was only training up the occupational therapists. Here you can see a table from the publication. We've got the mean age of participants. So on average, they were 60, but the youngest person was 18, and the eldest person was in the late 70s. The average time post-stroke was just over a year, but some people were 2 to 4 months post-stroke, and up to 46 months or 4 years. Most people attended 9 or 10 days, but we didn't get everybody attending 9 or 10 days. Obviously, if you don't attend 9 or 10 days, the number of hours of CIMT you receive is quite reduced. So you can see at the bottom, one lady only attended for 9 hours, and she had a medical event that stopped her from attending. So the number of supervised sessions she had was quite reduced. And as a consequence, the number of repetitions she completed was less than 2,000. So we have a very big range of repetitions here, and this is why we have trials. We have randomized trials and then systematic reviews, because it would be very tempting to just look at the outcomes for the people who did really well and who did high repetitions. But of course, what we see here is a reflection of typical practice. We've got 16 different people, some who worked harder and were able to do more repetitions than others. And here you can see the mean repetitions in week 1 and week 2. So we were getting a good 300 repetitions on average per hour. This graph shows you the 3 different health services. We were aiming for 250 repetitions per hour. The blue example, Sydney, the red bars are Tasmania, and the right-hand bars are Townsville. So we were really trying to push people to do 300-400 repetitions an hour, probably making people work a little bit too hard in some sense, and not allowing enough breaks in between the time trials. So when we did the training workshop with Dave Morris, we learned that it's good to have a little bit of a break in between the time trials to give people feedback. Of the 16 people who were recruited at the end of 2 weeks, you can see here the mean scores and the change between baseline and the end of the program. I'm going to focus mainly on the box and block test. So we've got on average 10 points or 10 blocks more being moved on average. But there was a bit of a range, and the 9-hole peg test was a little bit faster as well. We also were able to recruit 14 people back for their outcome measures at the end of a month later. And if we look at the box and block test, you can see that they maintained the performance here. and 9-hole peg test a little slightly faster. At the end of a year, we were only able to get 8 people's data from 8 people, but we can see what you often see in some of the published studies, that there was a maintenance of the gains. But we've got to remember that we lost half of the sample, so we can't be too certain how they went. They might have been very poor or done fabulously well. Now, I'm going to finish by talking about how we spent the time and where most of the time was spent. Obviously, there's time delivering the program, and that's quite an intensive period of time, but you have to spend quite a lot of hours preparing and persuading people to deliver the program. So I don't want to scare you by telling you how many hours are going to be required, but you do need to anticipate and invest a fair bit of time. And if you run a program, you want to be able to run it more than once because of the hours you've invested. So we spent time emailing people like Dave Morris, Ted Stevenson in Canada, and we also attended training workshops and read up on some of the materials that we needed to read up on. But a lot of time, 60 hours, was spent usually mostly by one therapist at each site, preparing the logbooks, meeting with their managers to persuade them that the evidence was strong enough to need to deliver this. Also attending phone meetings. We didn't have Zoom back in those days, so we would meet by phone about once a month or once every 2 months to learn how to deliver CIMT. Organizing transport, booking rooms, getting medical consent, and organizing a roster of staff would take quite a bit of time. Phoning and finding participants to attend took time, and the baseline measures would take a couple of hours at least per person. As I mentioned before, the therapists took videos and made photographs, and they had to store them and save them. And they had to plan what equipment and tasks would be done and prepare slides for the training sessions. Mostly they ran a half-day training session for their team. And they would usually do that after they had done the baseline assessment. So they had a video of some of the stroke participants doing, say, the 9-hole peg test or the box and block test. And that was helpful to show people who might be working with them. Of course, delivering the program took a lot of time, 4 hours a day, but there was also time writing up the progress notes for each individual in the medical file, storing the recordings, setting up and packing away equipment. I mentioned that they had to move rooms, so there was quite a few boxes of equipment. And this was where students and volunteers were helpful. All of the sites planned the programs when they had a student on placement, either a 3rd or a 4th year student on placement. And of course, you have to plan for the next day, and that takes a bit of time. Finally, the follow-up measures were important, and putting them into an Excel file and then sharing that with the team, because you want to be able to show the successes and convince management that this was a good use of your time. So this table is in the journal article that I mentioned before for anybody who needs to follow it up. So the take-home messages are that here in Australia, we were able to deliver these programs across different health services without any additional money, without any additional staff, but we used students at every site, and we also sometimes had some volunteers that were unpaid. We generally wouldn't choose to run a program like this without a student on placement to help. You can't guarantee the caliber of student you're going to get, but at least you can give them jobs to do, including filing and counting repetitions and so forth. We were able to show statistically and clinically significant changes in the upper limb of the stroke survivors who participated, so that was pleasing. Formal training was really essential, so attending a training workshop and then training up the staff involved, but having mentoring and a community of practice. So we would recommend that. And Lauren Christie has included that, as you'll hear shortly, with the 9 teams that she trained and helped. The management support was also really essential to make sure that this wasn't a program that would stop before it got started. But as you can see, there's a lot of investment of time. So you need to make sure you're going to be delivering more than one program. And if you have a lot of staff who are part-time, make sure you train up more than 1 or 2 people. We didn't have an awful lot of people who could attend the CIMT programs, even in a large area of Sydney. So we suggest that you plan to run both one-to-one and group, and you perhaps have people who can come from different areas, not just your own site. If you would like to contact me then, or any of the staff involved, this is my contact detail. Thank you.